Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
Hello, I'm Jeff Weinreb, Senior Research Scientist and Professor Emeritus at Yale University. Welcome to this activity called Precision Imaging in MRI, Brain MRI. Joining us today is Dr. Max Wintermark, who's professor in the Department of Neuroradiology and chair of the Department of Neuroradiology at the University of Texas MD Anderson Cancer Center. Welcome, Max.
Thank you, Jeff. Thanks for having me.
So, Max, we're here to interview you today about all things brain MRI. And for the audience, we will be taking questions, and this can be your opportunity to ask an expert. You can submit your questions anytime during this interview. Let's get started with the first question. So Max, brain MRI scans are done routinely for an enormous range of clinical conditions. When protocoling an MRI scan of the brain, one of the most important decisions you have to make is whether or not to administer an intravenous gadolinium-based contrast agent. Can you comment on how this decision is made and how you weigh the potential benefits against the potential drawbacks of injecting contrast for brain MRI?
Yes, Jeff, thank you. That's a great question. So the first thing I would like to say is we make that decision individually for each patient. So we look at each patient we schedule to get an MRI. We look at what is the clinical questions that the referring provider is asking us, and then we try to tailor the MRI study to be able to answer that question. And that includes different factors. It includes deciding the type of sequences that will be included in the MRI. And as you mentioned, it will also include the decision of administering a gadolinium contrast agent or not. When we make that decision, we try to balance the benefit and the potential risk for that very given patient. We try not to give contrast if we can answer the question without contrast. But in a number of instances, the administration of contrast is going to allow us to gather more information that we wouldn't have without administering that contrast agent. We look at special population of patients. If patients have renal failure, of course, that's going to influence our decision to give contrast or not. We'll try to avoid it even more. And also, if we know that a patient is going to have repeated scans, we're also going to be a lot more conservative in terms of administering contrast. And then again, at the end of the day, we try to take into account all of these factors. We look at each patient individually at the clinical question that is asked, and we make individual decisions for each patient.
There are a number of questions about high relaxivity agents. So first of all, again, for our audience, if you can just explain what a high relaxivity intravenous gadolinium agent is, and in what instances do you think it's useful or should be used?
Mm-hmm. So, there are different classes of gadolinium contrast agents, differ from each other in a variety of ways, but one of them is what is called the T1 relaxivity, which is the kind of the amount of enhancement that you get for a given dose of gadolinium contrast. Recently, some contrast with ultra high relaxivity have been made available and approved by the FDA. And one of the advantages of those contrast agents is that you can administer a smaller dose of gadolinium and get similar, if not increased enhancement compared to a regular dose of regular gadolinium contrast agent. To switch gear a tiny bit, gadolinium contrast has been shown when administered repeatedly to accumulate in the body. There have so far no side effects that have been reported from this accumulation, but still the contrast is accumulating in the body. And finally, the last thing I wanted to mention is I told you earlier that when we consider, whether we want to give contrast or what contrast we want to use, we look at many elements, but one of them is patients who are going to get repeated MRIs in the course of their life. So an example are multiple sclerosis patients. We know that they are typically going to get a lot of MRIs in their life at regular intervals. They tend to be very young patients. And so, of course, that's a perfect example of a patient population where we try to minimize the use of contrast because, again, they are going to get many MRIs over the course of their life. They are potentially going to get many doses of gadolinium. And so we try to limit how much contrast they get. There are different ways to achieve that goal. The first approach, and we kind of touched on it earlier, would be to do MRI without contrast. And that's what is done sometimes. The concern is that potentially there are some new plaques that you could only detect after contrast that you wouldn't detect without contrast. So that's a consideration when choosing this approach. A second approach is to use those ultra-high relaxivity agents because potentially that way you can get the same results but administer only half the amount of gadolinium. So if you look at cumulative dose over time, it can have quite a big impact. And a third group of solution would be to use different AI techniques that are available nowadays to try again to administer less contrast and yet get the same images with the same information. So 3 avenues. And again, I use the patients with multiple sclerosis as an example, but the same considerations apply to other patients who also are going to need many MRIs in the course of their lives.
So Max, from our audience, there seems to be a lot of interest in the advantages and disadvantages of 1.5T versus 3T for brain imaging. I know this is a big topic, but can you sort of summarize your feelings about it or
Yes.
information about this subject?
Very good question from the audience. So as you see, it's a big topic. We could probably speak the whole hour about that topic, but just to be succinct, I think that there are definitely advantages to 3T scanning because you have higher resolution. You can see in more detail the brain anatomy, the different brain structures. So that would be a reason to use 3T. On the other hand, we have a lot of patients who have metal in them or metallic devices in them. And from that perspective, it's safer to obtain 1.5 T scans in those patients. So in my practice, at each of our sites, we try to have at least 1.5 T MRI scanner to be able to scan those patients who have relative contraindication to a 3T scan. And of course, we try to use the technology that we have available nowadays to make sure that the quality of the exam is comparable on the 1.5T and the 3T. And for most of the conditions, we can achieve that goal.
Can you comment about how perfusion imaging is done in your practice and where you use it and the value of it in these various entities?
Yes. So again, another great question. So the first thing I would like to remind our audience is that there are different ways of performing perfusion MR imaging. There are a couple of ways where you use contrast, and one type called dynamic susceptibility contrast imaging or DSC, you inject a bolus of contrast and you monitor the washing and the washout of that bolus of contrast with MRI. That's one method. A second method that also uses contrast is called dynamic contrast enhancement imaging, or DCE. Here you inject contrast and you don't monitor the first pass, but you monitor the slow extravasation of that contrast in the interstitial space. And finally, there are also ways to assess perfusion imaging without using any contrast agent. There are different ways, but one of them is called arterial spin labeling, or ASL. And for ASL, you magnetically label the patient's own blood in their neck, and then you monitor the way that magnetically labeled blood in the neck distributes in the brain, and you can extract some information about the cerebral blood flow. So in my practice, we use all of those routinely. We use them for patients with a brain tumor. We use them in different settings. Sometimes perfusion imaging is helpful to differentiate between a brain tumor and a brain tumor mimic. Example, you can sometimes have tumefactive multiple sclerosis plaque that may very well look like tumor on the conventional imaging, but they look very different from a brain tumor on perfusion imaging. So that's one example. We use it also to differentiate tumor progression from pseudo progression. So sometimes the effect of the treatment of the brain tumor result in imaging findings that look very much like tumor progression, but it's just the treatment effect. That's why it's called pseudo progression. And sometimes, again, perfusion imaging can help differentiate between those two conditions. You mentioned stroke, so perfusion imaging has also been used for stroke to try to characterize the penumbra, meaning not the infarct core, but the penumbra, the viable tissue that could be salvaged. The usefulness of that features has evolved over time at the pace of the different clinical trials that have been reported on. And my final comment for perfusion imaging, and I mentioned different application, differentiating brain tumor from a tumor mimic, or differentiating tumor progression from pseudo progression. I also want to make sure that the audience is aware that this technique is not perfect. So it doesn't give you the perfect answer in 100% of the cases. It's helpful. It provides you additional information compared to the conventional imaging, but it's not the magic bullet that gives you the perfect answer every time.
There's questions about DTI, diffusion tensor imaging. Do you ever find DTI useful clinically? And if so, in what scenarios would you find it to be really useful or even critical?
Yes. So DTI stands for diffusion tensor imaging. It's one of the form of diffusion weighted imaging where you look at white matter tracks. And so you acquire your diffusion weighted imaging in a certain way to be able to extract this information about the white matter tract. DTI is used clinically. We use it, for instance, for brain tumor patients. Because when the surgeon plan their surgery, they use the DTI and the tractography information to try to plan their approach. So that's one example of clinical use. It comes with a lot of caveats, and typically it's just the first indication for the surgeon when they decide their approach, but they are going to not trust the DTI completely. They are going to do a lot of intraoperative interrogation using different electrostimulation techniques because they know all the shortcomings of DTI for that application. So that's one example. For clinical use, DTI has also been used abundantly in the research arena to try to better understand mild traumatic brain injury. And again, it comes with limitations for a variety of reasons, and the results that were obtained in those research studies sometimes contradict each other. But typically, again, in the research arena, when DTI is used, it's for groups of patients, where you take 100 patients with traumatic brain injury and 100 patients without traumatic brain injury, and you compare those groups. There are recommendations by the American Society of Neuroradiology and other national society against the use of DTI clinically and at the individual level to make the diagnosis of mild traumatic brain injury in individual patients. And there are a number of reasons for that recommendation against using DTI in individual patients. And I think that would go beyond the scope of our discussion today.
So what about, just for example, a patient who's getting an MRI for a headache? Would it be best to use MRI for all headache MRIs?
Yes, so I think that's another very good question. As you hinted, the headaches come in many forms. There are a lot of different types of headaches. Some have what we call red flags, so meaning that they are accompanied, for instance, by neurological symptoms, focal neurological symptoms. So we try to get as much information as possible, either from the request for the MRI or from the medical records. At time also we'll call the referring provider to gather more information. And in general, again, it varies for each individual patient, but in general, there's a number of patients with headache where we will at first get just an MRI without contrast. It allows us to detect a number of abnormalities that can be associated with headaches. And for when there are those red flags that I mentioned earlier, either from the clinical perspective or based on what we see on the non-contrast imaging, then we'll administer contrast to those patients. To just mention one example, sometimes you have a headache because you have a brain tumor, and in that case, you'll need the contrast. But on the other hand, sometimes patients have migraines, they have had them for a long time, the MRIs, just to make sure that there's not an underlying cause. And in that case, it's very reasonable to start with a non-contrast MRI. And if everything looks normal on the non-contrast MRI, there is no need to administer a contrast agent. But if you see something abnormal on the non-contrast agent, the patient may need the contrast. And again, those are general considerations, but we make those decisions individually for each patient.
There's seems to be some interest in, and there is interest, of course, everywhere about using MRI in the setting of Alzheimer's disease. And so the question is, what are you looking for in Alzheimer's on MRI? And should these studies be done at 3T, or are they just as valuable at 1.5T?
Mm-hmm. So again, big questions, but I'm going to try to be, and probably more than one question in one, but I'm going to try to be succinct. So in the past, MRI was used, and other types of imaging actually, not just MRI, imaging was used to try to rule out a structural cause to the dementia. For instance, a big frontal meningioma compressing the frontal lobe and explaining the patient's decline in cognitive status. Nowadays, there's been a regain in interest because there are new treatments available for patients with Alzheimer and mild cognitive impairment. And some of those treatments are associated with a condition called ARIA. And ARIA comes in two flavors. You have ARIA-E, where you develop brain edema as a result of the treatment. And ARIA-H is the second flavor, where you develop microhemorrhages that can potentially lead to larger hemorrhages. And patients receiving those new treatments need to receive serial MRIs in order to try to detect early those possible complications of the treatment, ARIA-E and ARIA-H. And so there's been a regain of interest for MRI. For ARIA-E, 1.5 and 3T scanners are relatively equivalent. For ARIA-H, when you look for microbleed, perhaps Treaty has a slight advantage on 1.5T, but you can also detect ARIA-H on a 1.5T. And perhaps a last element for our audience to consider is because we have a large number of patients in the United States who are in that category of mild cognitive impairment, who might potentially benefit for those treatments. There's been some discussion on how we're going to accommodate all those MRIs for all of those patients. And so there have been national efforts, including by the American Society of Neuroradiology, to propose a standardized protocol across platform, across 1.5 and 3T, and even possibly considering those lower field portable MRI scanners that have become available. So it's still an evolving field, but definitive effort to try to, again, standardize the imaging care that patients with mild cognitive impairment need.
On another subject, this is a timely question that somebody from the audience posed, having to do with long COVID. Millions of people have been disabled by long COVID or myalgic encephalomyelitis. What progress in brain MRI imaging is there for this entity?
Yes. So here I think it's important to distinguish two things: research versus clinical care. So there's definitely been quite a lot of research done trying to use MRI to characterize and understand the mechanism of long COVID. Some imaging biomarkers have been identified, like, for instance, measuring the size of the olfactive bulbs in patients with COVID to try, again, to detect those patients. It's still, and all of what I just described has been done under the umbrella of research. There's still active research going on. There has not been really any of those research findings that have really translated to clinical practice just yet, but again, a lot of ongoing research.
So, brain fog has become a big issue. Is there a reason to do MRI? Is it to rule out other things, or are there specific findings that you're looking for brain fog?
Mm-hmm. Where I work, because a number of cancer patients, not necessarily brain cancer patient, but cancer patient, after they receive radiation, chemotherapy, developed brain fog, also called chemobrain, and a variety of other names. At this point, we typically do not obtain brain imaging as part of the clinical care of these patients, but as again, going back in the research arena, it's an area of active research because this condition is poorly understood. The number of treatment options is limited, probably because we don't understand very well the pathophysiology of this condition. So it's an area of active research. We typically don't use contrast, but a lot of different research efforts are trying to use functional MRI to try to understand better the mechanism of this disease, with the hope that it will lead to the development of new treatments.
Okay, so there's a number of questions here about head trauma. And let me just pick one of these. And the question is, what's the best imaging for head trauma? Is it CT? Is it MRI? Are there different times you would use one or the other with head trauma?
In the acute phase, typically CT scans are the imaging modality that is the most often used because they can be obtained very quickly. Also, some of those patients who have head trauma were involved in severe trauma that may have affected other regions of their body, their cervical spine, their thoracic or lumbar spine, their chest, their abdomen. And again, CT is a great modality to screen for traumatic injuries of the brain, but also of the rest of the body. And so, again, in the acute phase, CT is the imaging modality most often used. CT can detect acute traumatic brain injury that would require immediate neurosurgical care. And so that's another reason why CT is typically used in the acute phase. In the more chronic phase, MRI can be used to detect more subtle lesions that are not necessarily detected on a CT. For instance, sometimes as a result of a trauma, patients may have developed microbleeds. You are typically not going to detect those microbleeds on a CT, but MRI has specific sequences that are very sensitive to detect those microbleeds. So again, an individual decision to be made for each patient based on their clinical evaluation, based on the acuteness and the severity of the trauma.
Okay, so Max, we didn't have enough time to tackle all of the questions that people posed, but thanks so much for your great discussion. And to the audience, thanks for posing so many really terrific questions, and I apologize again for not being able to get to all of them. But thank you very much for joining us today.